I'd like to echo the words of many of my predecessors. I'm thrilled to be here, and I truly appreciate this opportunity to share these several days with all of my colleagues from around the world. It's my task to speak to you on diffuse large B-cell lymphoma. Is R-CHOP the answer, and perhaps beyond R-CHOP, which really is better descriptor. So in the days before rituximab and the days before colony-stimulating factors, there were many phase 2 trials trying to improve upon outcomes with standard CHOP chemotherapy, which was the standard of care for what we call diffuse aggressive lymphomas, an even more heterogeneous category than diffuse large B-cell lymphoma. And as you can see from this slide, the addition of new agents as well as intensification of the treatment appeared, at least in this series of phase 2 studies, to result in better clinical outcomes with higher complete remission rates and a greater percentage of long-term complete remissions. But these were all relatively small phase 2 trials. And we all learned the lesson soon thereafter when the U.S. intergroup compared four of those regimens, 3 of the more intensive regimens, against the standard R-CHOP, showing how badly we really needed a large randomized trial to address this issue, and how there wasn't a difference at all in clinical outcomes with what appeared to be more intensive, more complicated regimens. CHOP merged the standard of care, and that's because it had the same outcomes. It's the same outcome, but less toxicity than the more complicated, more intensive regimens. So I think the lesson for us is one that we should have learned many years ago now, is the need for these very large randomized trials with head-to-head comparisons of what appear to be better regimens when studied in phase 2, in the phase 2 setting. Well, with the availability of colony-stimulating factors, the issue of what became known as dose density was readdressed by numerous groups, including the German high-grade lymphoma study group. And in this clinical trial, they compared the standard CHOP regimen, the standard CHOP regimen administered every 14 days with colony-stimulating factor support, which was now available, versus what we knew as standard CHOP. They also, in this more complicated study, addressed the issue of adding etoposide, which resulted in considerable toxicity. And as you can see from this figure, the outcomes at 5 years were statistically better with the more intensive dose-dense regimen CHOP administered over just 2 weeks, surprising many of us. Well, along came rituximab around that time, while some were reinvestigating dose intensity or dose density. The GLA, the French, as well as the North Americans, addressed the issue of adding the new anti-CD20 monoclonal antibody rituximab to standard CHOP chemotherapy. It was thought to improve outcomes in small numbers of patients, and hence the GLA trial comparing CHOP to R-CHOP was conducted. And this is the recently published long-term update, the 10-year update from the GLA, showing this incredible improvement in median progression-free survival from 1.2 years to 4.8 years, a substantial improvement. And you see that over time, these curves still remain separated. Overall survival as well was significantly improved from 3.5 years, the median overall survival, and these are all patients over the age of 60. Median median overall survival increased from 3.5 years to 8.4 years. And again, even at 10 years, these curves were well separated. Well, this established R-CHOP as the new standard for the treatment of diffuse large B-cell lymphoma. And the question then becomes how to go forward, how to improve upon these outcomes, because as you can see from this curve, the majority of patients still die of their disease. So one question is whether or not in the days of colony-stimulating factors, whether readdressing the issue of dose density made sense, or how about high-dose chemotherapy with peripheral blood stem cell transplant as part of initial treatment for patients with large cell lymphoma, at least for the younger patients. Other issues, other options were to add maintenance therapy, rituximab, or perhaps other agents after the achievement of complete remission. The use of an infusional schedule has been one strategy that's been investigated, led by Dr. Wyndham Wilson at the National Cancer Institute in the U.S., or perhaps the addition of new agents, new antibodies, new targeted therapies. And lastly, perhaps my mantra for this presentation is recognizing the biological heterogeneity of the large cell lymphomas and treating these various subsets according to their unique biologies. So back to the issue of dose density. Given the availability of colony-stimulating factors, there have been two large groups who have readdressed the issue of dose density in the age of R-CHOP. This study, both studies have been presented but not published in full form. This was a randomized trial from the GLA, again looking at R-CHOP every 14 days with growth factor support versus an every 21-day schedule. As you can see from this summary slide showing the clinical outcomes for these patients, I draw your attention to the right. There's absolutely no statistical difference for any of the clinical endpoints, whether it be event-free survival, progression-free survival, overall survival. So it did not appear in the age of rituximab that delivering R-CHOP on a more dose-dense schedule would improve outcomes. This was a second trial presented at the ASCO meetings, and we await the final word on this clinical trial, but larger number, over 400 patients in each arm addressing the same question, and again, no difference in overall response rates, complete response rates, etc. And so, at least for the moment, there would appear to be no advantage to R-CHOP 14 compared to R-CHOP 21. But that does not tell us that other dose-dense regimens might, in fact, improve outcomes, even in the rituximab era. And one such strategy was recently presented at the American Society of Hematology meetings by the GLA. They had developed a regimen called ACV-BP, which is much with increased dose density compared to R-CHOP. There are 4 induction cycles administered every 2 weeks, followed by sequential consolidation using agents we ordinarily reserve for salvage therapy, and aggressive CNS prophylaxis, because a small subset of these patients will in fact relapse in their central nervous system. This slide shows the event-free survival from that presentation. And as you can see, there are significant differences. These are all younger patients with diffuse large B-cell lymphoma. The R-ACV-BP arm here is statistically superior over the R-CHOP arm with a very significant change in hazard ratio, 0.56. The event-free, 3-year event-free survival was 81% in the experimental arm and only 67% in the R-CHOP arm, very encouraging. And you can see also there is significant improvement in overall survival. Not without cost, however. There's significant mucositis in these patients, albeit no major difference in death rate. And this particular strategy remains very provocative, and the question remains whether or not, with longer follow-up, this strategy will prove superior to standard R-CHOP and gain a foothold in the treatment of diffuse large B-cell lymphoma elsewhere, apart from in the GILA experience. Now, what about other ways of intensifying therapy for diffuse large B-cell lymphoma? What about incorporating auto stem cell transplant with high-dose chemotherapy as part of the upfront therapy for these patients, particularly those felt to be at high risk by virtue of their risk factors by the IPI? Previously, there had been a number of randomized trials using stem cell transplant as consolidation after full course induction, but none of these studies had incorporated rituximab as part of induction. As you can see from the right here, there was no significant difference between the arms in any of these clinical trials. But to address this issue in the era of rituximab, the U.S. intergroup modified an existing clinical trial to incorporate rituximab or R-CHOP induction for patients with newly diagnosed large cell lymphoma who were at high risk and were transplant candidates by virtue of age. And this clinical trial will be presented at the ASCO meetings. About 50% of the patients were induced with CHOP and about 50% with R-CHOP, 5 cycles, and then responders were randomized to either proceed to stem cell transplant after one further cycle of R-CHOP or to complete their standard induction therapy. And it's hopeful that this particular trial will provide some definitive answer to the question of stem cell transplantation for newly diagnosed patients with large cell lymphoma. What about the concept of maintenance? Does it make sense to administer additional therapy after the achievement of complete remission in patients with diffuse large B-cell lymphoma? Well, the U.S., at the time that the GILA conceived their study comparing CHOP to R-CHOP, the U.S. intergroup did the same. Our study was a little bit more complicated and led to some issues regarding final statistical analysis, but it was in similar randomization between CHOP and R-CHOP, with responders then randomized to maintenance rituximab, or observation. So this was a second randomization for responders only. And in this trial, among 352 evaluable responders who were randomized either to observation or 2 years of maintenance rituximab, there was absolutely no difference in clinical outcomes for those patients who were induced with R-CHOP. So if the upfront therapy was R-CHOP, the additional rituximab made absolutely no difference. However, for patients who received CHOP only, the maintenance Rituxan had a very profound effect on time to treatment failure. The concept of maintenance therapy is now being addressed using some of the newer agents that are available, including enzastaurin and a PKC beta inhibitor. A clinical trial randomizing responders at high risk of recurrence to enzastaurin or to observation has been completed, and the results will be forthcoming sometime in the future, sometime perhaps in the next year, and we await those results. Other clinical trials with other maintenance agents are being investigated. Now back to our clinical trial, the U.S. intergroup randomized trial comparing CHOP to R-CHOP. The long-term follow-up of our clinical trial was recently presented at the American Society of Hematology, and I think the results underscore the importance of large randomized trials and also of tell us something perhaps about the heterogeneity of the diffuse large B-cell lymphomas. So this is the failure-free survival according to the induction randomization, comparing patients who were induced with R-CHOP to those with CHOP, showing that the differences still are maintained for failure-free survival. However, if we look at the overall survival curves, you'll see that they start to come together, and that there's no longer with long-term follow-up, no longer a statistical significance between patients induced with CHOP compared to those with R-CHOP. This is in contrast to the results presented and published now by the GLA, where you saw earlier, I showed you those nice continuing differences between the two curves. So the reasons for this remain somewhat unclear. When analyzed according to the International Prognostic Index risk group, we'll see that for patients who were at low risk of treatment failure, the curves come together with long-term follow-up. However, that nice difference between the curves that you saw in the GLA results is maintained in our study for the high-risk patients. Why these differences? The GLA, when they looked at their risk groups, they had the same, among their low-risk patients, they had excellent separation, suggesting that there's some difference between their outcomes and our own, particularly for the low-risk group. To understand that, I think we have to look more carefully at the heterogeneity that is the diffuse large B-cell lymphomas. And although we stratify in our clinical trials and we look at between the IPI risk groups and we look carefully at the IPI risk groups, we're clearly not addressing all of the heterogeneity that exists in this disease. And we'll go on to talk a little bit more about that. So I think that's my segue into discussing heterogeneity in general in the diffuse large B-cell lymphomas. I think the clinical heterogeneity is apparent to all of us who treat this disease, a wide variety of clinical presentations, the variety of outcomes, some patients who have very aggressive disease and die within months, and others who have what appears to be an indolent process. We know morphologically our pathologist friends are identifying an increasing number of subsets. More recently, a new subset called the EBV positive diffuse large B-cell lymphoma of the elderly has been added. And as time goes on, a greater number of these subsets have been dissected out of this larger group of diseases. Now, using our more modern molecular techniques, it's been possible now to look at gene expression patterns and to further dissect the heterogeneity that is the diffuse large B-cell lymphomas at the molecular level. And this is from a classic paper from Lou Stout's group looking at gene expression patterns in a large number of patients treated with standard CHOP chemotherapy. And what you can see is that there are at least 3 discrete subsets by gene expression patterns, and that these 3 subsets represent disease that appears to derive from cells that arise in different parts of the lymph node in the germinal center. Excuse me. It's very sensitive here. You see in this group here, we have the germinal center GCB, or germinal center B-cell derived large cell lymphomas with a fairly uniform pattern of gene expression, which contrasts with the activated B-cell large cell lymphomas. And here we have a third subgroup, the primary mediastinal B-cell lymphoma pattern. These have these gene expression patterns and these separate defined discrete groups that have very distinct clinical clinical behaviors, with the GCB subset having a improved outcome compared to the activated B cell subset. And this holds whether or not the patients are treated with CHOP or in a larger analysis also performed by the Stout Laboratory in patients treated with R-CHOP. You also see the excellent outcome for patients with primary mediastinal B-cell lymphoma. Now, these are likely not the only subsets in this large heterogeneous group of diseases, and I think as time goes on, we'll see more and more subsets culled out. What's important is the differences in biology between these different groups. And this is from my own work, from the analysis, the correlative studies that have been done on the cases enrolled on the R-CHOP versus CHOP U.S. intergroup trial. And here we used rather simple techniques, since this study was conceived in the 1990s before gene expression profiling. And we used immunohistochemical techniques to look at prognostic factors in the diffuse large B-cell lymphomas. We found that BCL6, a very powerful prognostic indicator among patients treated with CHOP, lost its prognostic significance when R-CHOP when patients were treated with R-CHOP. When analyzed slightly differently, according to BCL6 positivity, what you see is that patients who are BCL6 positive appeared to have the same outcomes whether they were treated with rituximab or without, with a very different outcome for patients who are BCL6 negative, who appeared to benefit from the addition of rituximab to their treatment. Now, this is intellectually very interesting and suggests to us that there are discrete subsets in the diffuse large B-cell lymphomas that behave differently and respond to different treatments, and that we need to look individually at the heterogeneity of the large cell lymphomas and to prescribe therapy accordingly. One could take home from this data, and this remains to be confirmed by other groups, that it doesn't pay to treat many of the large cell lymphomas with rituximab. I think we will, in the future, be designing therapies specifically for the biologic markers or for the biologic subgroup that we've identified. Now, what about infusional therapy? So Wyndham Wilson, who had recognized that proliferative activity was an important prognostic marker in the diffuse large B-cell lymphomas, and had also recognized some of the same findings in his own data with regarding rituximab's effect on discrete subsets. So it would appear to many of us that rituximab benefits a subset of patients, and Wyndham hypothesized that rituximab would overcome ABC-related resistance in the subgroup of patients that derive from the activated B-cell subtype, and designed a regimen called EPOC, which is basically infusional therapy, in which several of the drugs are administered by prolonged infusion over several days. In a phase 2 trial conducted first at the National Cancer Institute in the U.S. and then in the Cancer and Leukemia Group B, he showed these excellent outcomes, again, for about 100 patients with diffuse large B-cell lymphoma. Again, if you remember way back to that first slide I showed, we can often be seduced by the results of phase 2 clinical trials, and so learning from the lessons that we learned in the early 90s from the U.S. Comparison of CHOP and the more intensive therapies, a clinical trial comparing our CHOP to Wyndham's dose-adjusted EPOC regimen has been designed and has been active in the U.S. for several years now. This is a direct comparison. It involves all the cooperative groups in the U.S. And what's unique about this clinical trial is that it is attempting to address the biologic heterogeneity by obtaining specimens on every case enrolled on the clinical trial, performing extensive molecular analysis, gene expression arrays, and other studies to try to cull out what the differences might be among these different subgroups and how they respond to these two different regimens. So it may turn out that R-CHOP is equivalent to dose-adjusted EPOCH for the group overall, but that certain discrete subgroups benefit from one therapy over the other. So what about adding new agents that in particular address the survival pathways that are unique to specific biologic subsets? And this is one approach that's been taken by the Mayo Clinic group, and that is to add a new antibody, ebrutuzumab, an anti-CD22 antibody, to R-CHOP. And again, these are exciting data with excellent outcomes, albeit again a phase 2 clinical trial that will need to be compared to R-CHOP in a phase 3 clinical trial that is under design. Well, back to our issue of addressing the unique biology of these individual subsets. The NF-kappa B pathway is a key pathway among the ABC subtype, the activated B-cell derived subset of diffuse large B-cell lymphoma depends for its survival to a large degree on this particular pathway, and you'll see how important the proteasome is to this pathway. Well, John Leonard from Cornell, Dr. Coleman's group, investigated the addition of bortezomib, a proteasome inhibitor, to R-CHOP, and subsequently analyzed the cases enrolled on that clinical trial to determine whether or not they were GCB or non-GCB derived. John was surprised to find that there was no difference in the clinical outcomes between the GCB and non-GCB subsets. I showed you before that among CHOP-treated patients, the GCB or germinal center B-cell derived subset has a better prognosis, and that's true also among the larger R-CHOP series. And so the elimination of the difference between these two subgroups is very provocative, suggesting that the use of proteasome inhibition in addition to R-CHOP will address the poor prognosis associated with the non-GCB subset. So this is a particular example of how we can address the unique biology of these various subsets. A phase 3 randomized trial is now underway, enrolling only patients who have the non-GCB subset of lymphoma. So taking those patients who are believed to have the NF-kappa B pathway as one of its primary modes of survival and drug resistance, and randomizing those patients to receive either standard therapy with R-CHOP or the new intervention bortezomib with proteasome inhibition and disruption of the NF-kappa B pathway in addition to R-CHOP. So where are we going in the treatment of diffuse large B-cell lymphoma as our new techniques, our new strategies allow us to further understand and cull out the various biologic subtypes within this larger group of diseases? I think we're going to see combinations of traditional chemotherapy, perhaps dose intensification, immunotherapy with many of our new antibodies, but also targeted approaches, individualized therapy that is directed towards the specific survival pathways unique to specific subsets of diffuse large B-cell lymphoma. And I want to close with inviting you to Chicago for the 2011 ASCO meetings. We promise you fabulous weather, fabulous restaurants, and an excellent meeting. Thank you.